talk. I think we'll get started. People will still
Okay.
trail in, if
All
that's
right.
okay.
Yeah, that's
All right.
perfect. Ooh.
Okay, everybody, welcome. Thank you so much for joining us again at the Arthur Summer Rotenberg Suicide and Depression Studies Program Public Speaker Series on Suicide Research. I'm Sakina Rizvi. I'm the chair of this program here at the University of Toronto and St. Michael's Hospital. So again, like for those of you who are just joining us for the first time, our goal here of this series is knowledge sharing. There's so much going on in the world, and so many people working so hard on suicide prevention, intervention, postvention, and we want the public to know what's going on. So, if there's things that you'd like to know about, please let us know in our feedback form. We are planning our speaker series for next academic year, so we can try to incorporate your feedback there. We will be here on Mondays until June from 12 to 1 EST. You can sign up for updates on who's coming next in the link in the chat. Also, for this, if you could, for the QA, if you could use the QA function at the bottom, that would be great. I'll be monitoring that at the end. And also, I always like to mention, these talks are meant to inspire people, but we are still talking about suicide, and I want to make sure we're doing that in a very emotionally safe way. So if there's at any point you feel like you need to take a break or, do whatever you need to do to support yourself, if you're feeling away, please do so. And this will be recorded, and so you're not going to miss anything. And just make sure you're always caring for yourself. Yeah. So I am so excited to introduce Dr. Arielle Sheftall. She's an associate professor in the Department of Psychiatry at the University of Rochester Medical Center. She is also the chief of academic affairs for child and adolescent psychiatry and affiliated faculty in psychology. Her research focuses on mechanisms in early to middle childhood that can lead to vulnerability for future suicidal behaviors. And really, the hope for that is to find targets for early intervention that can decrease first suicide attempts. And also, Dr. Sheftall studies the racial disparities present in suicidal behaviors among youth. She was a member of the Congressional Black Caucus Emergency Task Force that developed the Ring the Alarm report. And she continues to examine risk factors, practice, and policy recommendations necessary to decrease suicidal behaviors in Black youth. She's also served as a subject matter expert for the American Foundation for Suicide Prevention, Substance Abuse Mental Health Services Administration, focusing on mental health promotion for Black individuals. So she's got a lot of knowledge on this topic, and we're really excited to hear about the work she's been doing. She's also a Green Bay Packers, Columbus Crew, and Boston Celtics fan. So unfortunately, not in the Super Bowl this year, but hopefully next year. And thank you so much, Ariel. We're so happy to have you here.
Well, thank you so much for that introduction. I'm going to go ahead and share my screen so that you guys can see. All right, perfect. So we're going to be talking about the landscape of Black youth suicidal behaviors. Before we get started, just so everyone is aware, I do receive funding from the National Institute of Mental Health here in the US, and also have received past funding from the American Foundation for Suicide Prevention, and have no other financial relationships or conflicts to disclose. So, one of the most important slides that I show every single time. So, this is a slide of all of the numbers that well, not all of the numbers, it's not exhaustive, but these are the numbers that I know of in the US. And also, I pulled up some of the Toronto numbers if you're there, that you can contact whenever you feel the need to do so. It doesn't have to be a crisis moment. It can actually just be a moment where you're just feeling not yourself, feeling very down, feeling blue. And these are opportunities for you to just call someone and speak to someone. They're always available 24 hours a day, 7 days a week, 365 days of the year. So you can text, call, chat with 988. You can call 211 in Toronto. And if you don't do one of those things, that's fine too. Just go to the closest emergency department. There always is someone available. And I think that that is something that's really important to stress before getting into the details of the presentation. Also, do not feel bad if you have to step away. Suicide, suicidal behavior, these are very sensitive topics. We are okay if you need to take a moment and just stop listening to me. That's fine. Please do not hesitate to do so. Take care of you first. That's really what's most important. This is recorded, so you can always come back to it if you'd like to. So, in terms of definitions, so that we're all on the same page, when folks in the field say suicidal behaviors, we are actually talking about three different items or different words. It's the umbrella term that we use to discuss suicide, suicidal ideation, and suicide attempts. Suicide is the death of a person that is caused by an injury to oneself, and there has to be explicit or inferred intent to die that's present for it to be coded as a suicide. Suicidal ideation is having thoughts about suicide, and those can range. It can be something where you wish you were dead, wish you go to sleep, never wake up again, all the way up to an actual plan and method in mind. Suicide attempt is a non-fatal self-interest behavior that is done to oneself, and the intent to die either is stated or inferred. So those are the three terms that are under that umbrella term, suicidal behaviors. Non-suicidal self-injury is another term that you might hear, and that is actually hurting oneself on purpose without the intent to die. So unfortunately, we do know that non-suicidal self-injury or NSSI is related to suicidal behaviors, but is not considered one of the umbrella terms because the intent to die is not present. So now that I've given you some background on definitions, I really want to focus a little bit of energy on the epidemiology of Black youth suicide, specifically in the United States. So, this is for youth specifically, 5 to 17 years of age. And what you'll see here is that I've plotted it out for total. So, that's that black line, that one right here at the very top. And then we've got males in the middle, which is the yellow line, and green is the female line. And what you'll notice here is that all of the rates are increasing. We have seen a bit of a decrease from 2022 to 2023, but when you look over this period of time, what you'll see is that for males, we actually seen a very small decrease. It's 2.2%, but for females, we've actually seen an increase of 17%. So that is just something to consider when thinking about prevention strategies, thinking about interventions. Maybe we might be focusing our energies on one group versus the other when you look at suicide overall. But for Black females, that is one group that has not been focused on and might be an opportunity for prevention. Also, when you look at the United States as a whole, this is the map of the US. And what you'll see here is that we've experienced some decreases in certain spots in the US, but have not in other spots. So in the South, we've actually seen an increase of 11.5% from 2018 to 2023. And on the West, we've actually seen an increase as well of 19% for Black youth 5 to 17 years of age. But for the Northeast and the Midwest, we've actually seen decreases. So unfortunately, I'm in the Northeast. You guys, Canada, Toronto's in the Northeast. So we have seen decreases. So we are doing something well, but it doesn't seem to be nationwide. So still have a lot of work to do. So some of the research projects that I have conducted with Black youth specifically, suicidal behaviors, I'm going to go through those. So this is the first one. So what we found back in 2018, we actually were looking at suicide in Black youth compared to white youth. And we looked from 2001 to 2015, and we looked by age. So you can see here, this is the age in years, and this is our statistic that tells us what's going on. And what we found is that for Black youth specifically, from 5 to 12 years of age, they're approximately 2 times more likely to die by suicide than their white counterparts. And then it flipped at age 13. So at age 13, they were actually less likely to die by suicide than their white counterparts. And this was probably the second paper that made the big splash, that people were starting to recognize that suicide was actually a problem within the United States for Black youth specifically. Then I did a paper where we looked at Black youth suicides only. I wanted to really focus energy on Black youth suicide and not have to compare it to white youth or Hispanic youth, but just let it be. And what we did first is we looked at it by age, we looked at it by sex, and then we also looked at precipitating circumstances. So by age was the first, and we broke it down by groups. So this is for Black youth, 5 to 11 years of age, from 2003 to 2017 in the United States. And we plotted it out. And what we found is that for Black youth, 5 to 11 years of age, there was an average percent increase of 3.9%. And then for our 12 to 14-year-old age group, they were actually the ones that saw the lowest increase. So it was 2.9% for them over this time frame. And then for our 15 to 17-year-old youth, they actually saw the largest increase at 4.9%. And then we looked at sorry, oops, get that out of there. Oh no, I apologize. Okay, by sex. Here we go. So the blue line is males and the gray line is females. And what you'll notice here is that both increased over this time period. However, our females actually experienced a larger increase than our males did, almost double that of what the males did. So it was 6.6% for our females over this time frame, and it was 2.8% for our males. Then we looked at precipitating circumstances. So what was actually happening around this death? What was going on? And we looked at it by age group, and we also looked at it by sex as well. And what we found is for our 5 to 11-year-olds and our 12 to 14-year-olds, there was a lot of commonality that was happening for these youth. They all seemed to die, well, majority of them seemed to die in their home. A majority of them experienced a problem with their family, with school, or a family crisis or a school crisis had occurred prior to their death. And they all died within 24 hours of an argument. The one thing that we did find that was a little bit different from for these two groups specifically was that for our 12 to 14-year-olds, they were more likely to be diagnosed with ADHD. Excuse me, the 5 to 11-year-olds and the 12 to 14-year-olds, when you compared them to the 15 to 17-year-olds, I apologize, the younger kids were more likely to be diagnosed with ADHD. And there were also more females present in these age groups compared to the other age group. And then for our 15 to 17-year-olds, they were more likely to have boyfriend-girlfriend problems, more likely to leave a suicide note, more likely to be diagnosed with depression or dysthymia, and then also to have substance use concerns, recent criminal or legal problems. When looking at our girls, so this is over the age groups, they were more likely to have relationship problems, crises, die within 24 hours of the argument. They were also more likely to have mental health concerns. So whether that be current, treatment that they were receiving, whether they had past treatment, whether they had a history of suicidal thoughts and behaviors that all tended to be more often in girls than it was in boys. And they were also more likely to be diagnosed with depression or anxiety or dysthymia. And then also another thing that came out for our girls was physical health concerns. And I should go back a little bit to kind of give some highlights. These differences that I found for this specific research study seem to be an opportunity for intervention. So for our younger kids, remember they were more likely to have ADHD and they were more likely to have females present in their age groups. It might be an opportunity to think about maybe doing prevention programming for Black females only 5 to 12 years of age or 5 to 14 years of age. And then another way of thinking about it is maybe talking with pediatricians because pediatricians are more likely to manage medication for ADHD diagnoses. So maybe thinking about screening or thinking about med checks and doing those med checks and incorporating screening for the pediatricians. So this could be an opportunity as well. It looked at looking at physical health concerns. So, not just trying to treat the physical health concern itself, but maybe getting some more screening about mental health when talking about physical health concerns might be a point of intervention as well. And then finally, for our boys, they were more likely to be diagnosed with ADHD and also more likely to have a recent criminal or legal problem. And that might be an opening for intervention as well. Working with juvenile justice, the juvenile justice system in the United States can be quite challenging, but that doesn't mean that it's not needed. I think that there are opportunities for us to prevent suicide and suicidal behavior. Um, and it might just be getting into the system to be able to make those changes present. So this is the survey that's done, the Youth Risk Behavior Surveillance Survey that's done every other year. And this is only for high schoolers. It's done nationwide in the US, ninth grade to 12th grade. And it started in 1991. They do have data for 2023 now, but it's not on this slide. But I wanted to just show you guys what they actually presented and what you'll see on the bottom is that every single line represents a different type of suicidal ideation or attempt. So this blue line right here actually represents suicidal ideation, considering suicide. Our yellow line represents a plan for suicide or suicide attempt. This line here it's black. It's actually attempts and then the last line is attempts that actually led to medical attention. And what you'll see for Black youth, ninth to 12th grade, from 1991 to 2021, we've actually seen increases in all of these types of behaviors and thoughts. So for our medical attention specifically, it's seen the highest percent change. So from 1991 to 2021, 144% increase is present for attempts that required medical attention. And even attempts period, 120% increase over this period of time. They do have a middle school survey that they conduct every other year as well. However, it's not nationwide. It's only for certain cities and then also certain states that provide data. Another paper that I was able to write looked at another vulnerable group of youth, Black youth within the child welfare system. And I really wanted to focus some energy on protective factors. I think a lot of what we do within the field is focusing on risk, 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 which again, not bad, but now that we know what those risks are, what do we do with it? So this paper was really about just looking at protective factors and what were those protective factors for Black youth that actually were in the child welfare system in the US. So we do know that youth who are in the child welfare system, they're about 2 times more likely to actually experience suicidal thoughts and behaviors. And unfortunately, Black youth are overrepresented in the child welfare system. For this specific study, we used the National Survey of Child and Adolescent Well-Being, and we looked at Black youth who had at least one or more follow-ups, and we looked at a large age range, 7 to 17 years of age, and we looked at social skills, loneliness, child maltreatment, and demographics. So what we found, unfortunately, which is very true in the literature, you will see this over and over and over again, that previous suicidal thoughts and behaviors was associated with youth suicidal thoughts and behaviors. Unfortunately, that is the risk that puts youth at the highest risk for engaging in suicidal behaviors later on. We also did find some good things. So, parent and teacher rated social skills. So, if parents and teachers rated their children to have really high social skills, that actually created a buffer, so to speak. It actually protected that youth from engaging in suicidal thoughts and behaviors. And then for loneliness and dissatisfaction, social dissatisfaction, that did increase those behaviors seen. We also looked at age as a potential interaction or a moderator. And what we found is that for our 11 to 14-year-olds and our 15 to 17-year-olds, they had a lower odd of actually having suicidal thoughts and behaviors compared to our 7 and 10-year-olds. So again, focusing on that younger age group, although we don't want to believe that suicidal thoughts and behaviors can occur that young, these studies and the studies that we conduct every single day tell us that that's not truly the case. They are occurring at this younger age, and unfortunately, even occurring more than our older youth. So, what do we do with all this information, right? Where do we go from here? Well, I do have good news. Suicide is preventable. I believe that with everything that I have. I believe with that with my heart, my mind, everything, that it is preventable. And I think we do have a lot of work to do, but in the end, I do believe that lives can be saved. There are a ton of risks that we don't discuss, unfortunately. And in the US and even, probably in other countries. And it's definitely specific to Black youth. I would say that we don't really look at these risk factors, and they play a big role. Um, how people actually deal with historic trauma, how people understand stigma, how they feel less than other people. All of those factors play a role. And unfortunately, we don't have a lot of research in those areas. It is up and coming, um, but it's still brand new, unfortunately. We're getting there though. Getting there, keep on having to pump those papers out. And I do think research is needed. Um, it's really important for us to consider these culturally relevant risk factors for specific groups. So for my group that I am most interested in, Black youth, something to consider for Black youth specifically is stigma and discrimination. How is mental health stigma related to youth suicidal behavior? Is that stigma something that they're experiencing from their friends, from their family members, from classmates, from what have you? And how does that play a role in how they think about suicidal thoughts and behaviors? Establishing theory. So we have a ton of theories, not a ton. We have a good number of theories within the field of suicide. But in order to actually test those theories and make sure that they're relevant, we have to have large groups of minority youth, um, specifically for me. to actually test these theories out and see if they are relevant. And if they aren't relevant, then we need to make some adaptations or we need to establish theories that are relevant. Also, investigating the trajectory. So, what do I mean by that? We had a paper that I wrote with Dr. Michael Lindsay at NYU, and we found that for Black youth specifically, they were more likely to report that they had attempted suicide, more likely to report that they had attempted suicide and had medical treatment from that suicide attempt, but they were not as likely to report ideation. So it's very interesting because in our world, we believe that ideation comes, then we have planning, then we have an attempt. Or sometimes just ideation comes and the attempt comes. But for these Black youth, there's a piece missing potentially that we're not focusing our energies on. So understanding what this trajectory from ideation to behavior actually is within Black youth will actually help us to better intervene. And then mixed method approaches. I believe that that's 100% necessary. We need to not just look at the yeses and the nos. We need to really talk to these youth and gain some insight from them about what does suicide, suicidal behavior, suicidal thoughts mean to them. I always go back to another uh, paper that I wrote with one of my colleagues where he focuses his energy on Asian youth. And he told me that you can't talk to Asian youth about depression. You can't just say that word. And the reason why is that it's very stigmatized. So he had to speak with youth and get an understanding of, okay, what are the words that I need to state in order to be able to actually look at depression? And what he found was that being tired was actually an opportunity to intervene. So again, there might be these nuggets, so to speak, of information that we're missing because we aren't talking to the right people. And then also thinking about positive psychology and strength-based approaches. There's one theory that I just recently learned a lot about, the developmental assets framework, or excuse me, the framework itself, that really focuses energy on positive assets, whether they be internal assets or external assets, and how they can actually relate to positive development for youth. But to my knowledge, it hasn't been used within the suicide prevention field. So thinking about these other strength-based approaches that might actually help us to combat the problem more effectively. So overall, I'm just going to put all these up here. Um, buy-in. Buy-in is so important. So, buy-in and trust from community leadership when working with Black youth and Black families and organizations that serve Black youth and Black families, you have to have that buy-in and you have to have that trust. And it's going to take time and it's going to take energy to build that trust and to build that buy-in, but it's 100% worth it. Connecting with mental health and behavioral health providers within the community that you're trying to serve, that is something that is really relevant because those people can be looked upon as leaders within the community when speaking about mental health. So connecting with those folks to make sure that you are actually engaging with them and helping them to provide information that would be beneficial to the families that they're serving, but also the community that they're housed in. Tailoring suicide prevention programs, we've kind of already talked about that. Take into consideration, what are those cultural aspects that need to be present? And then also listen. Listen. People in the community are very, very, very invested in helping the community itself at large. And I think it's important for us to not always come with a plan of action, It's really sometimes just listening to what the community needs, listening to the youth themselves. You might have a great, wonderful idea, but if the youth aren't buying in, it's not going to work. So I think that's something else to take into consideration is really think about um, just having those listening sessions with community leadership, with the youth themselves, so that you're getting both sides of the coin, so to speak. So that's all I have in terms of the outline of the research that I've done within Black youth and also just some tips for suicide prevention. But I did want to do something a little bit different to get you guys engaged. I have some scenarios of case studies that I wanted to just pick your guys' brains about um, and see if what you think. So I'm going to put them on the screen, and you are welcome, or you don't have to, but you're welcome to think about what are those protective factors that you see within this scenario? What are some of the risk factors that you see within the scenario? And what would be your first point of action to actually help this individual that's experiencing their circumstances that they are experiencing? So I will read it out loud. Um, and again, use your QA function or chat function and protective factors, risk factors, and then also first steps of action. So this is a Black youth, 17-year-old female. She's in her senior year of high school. She is a straight A student. She's a captain of her soccer team. Her parents often praise her for her achievements and hard work. She's been accepted to her dream school, Harvard University, for next year, well, this fall. And she explains that sometimes she feels so pressured and stressed that she can't handle it anymore. Sometimes she thinks about overdosing to show her parents how stressed she is. She thinks about suicide and maybe it would stop her stress or end her pain. She's not 100% sure. For the past year, she's had these thoughts about 3 times a week, and they last for about an hour at a time. She began cutting when she was 14 years of age to relieve stress. And during those times where she was cutting, she never had any intention on dying. She now cuts on her stomach and thighs 4 to 5 times, at least once a month. The most recent time she cut was on January 25th, 2026. She remembers because she had a game that day, a soccer game, and a test that day, and she was really stressed out about both of them. Plus, she records what days she cuts on her app, on her phone. She has never needed medical attention for the cutting. She's unable to control the suicidal thoughts when they happen, even though she tries to get her mind off of them. She tries to do other things. She's never gathered any pills or, taken any more of her medication than what she's prescribed. When asked, she says she doesn't really want to die and wouldn't act on these thoughts, but she's not 100% sure. She's looking forward to attending college, and this has stopped her from acting on her thoughts of suicide in the past. Okay, so that is the scenario. 17-year-old female, um, Black female, straight A's, all that good stuff. So, what are some of the protective factors that you guys would say are present in this scenario?
Feel free to use the chat function
Yeah.
for this, everyone. Oh, I'm seeing her parents. Supportive
Okay.
family,
Hmm. Yes.
strong student, wanting to go to college, positive
Hmm.
social connections, hope for a future, future-oriented community through soccer, looks forward to college,
Yeah.
um, self-insight,
Hmm. Wonderful.
future
And what are some,
goals.
yeah, and what are some of those risk factors that you're noticing? within this scenario?
Pressure to succeed,
Mm,
frequency of thoughts, lack of healthy coping skills, um, stressors, overall stress, cutting in concealed areas,
mhm.
how long, the duration she's been cutting for,
Yes.
fact that she records it, anticipational racism.
Mm,
Actions can be coping mechanism versus attempt to unlive. Perceived internal locus of control, societal expectations and cultural pieces. I was also wondering about perfectionism.
yeah. Yes. Yeah. Absolutely. All right. So if you had this person in front of you, as a patient, as a student, what would be the first thing that you would want to kind of uncover or the first actionable step that you would take? No, that's a tough
Yeah,
question.
that's a tougher one.
It is.
Make sure she was safe. Safety
Mm,
planning. Help her identify when thoughts of suicide occur. Listen. Engaging moments when she doesn't cut, even when she had the desire.
mm,
Implement outlets for decompression, maybe a family meeting, maybe not first, but soon. Identify who she feels comfortable talking to. Um, make a safety plan, remove means she uses for self-harm, identify her protective factor, safety planning,
yes.
coping skills when pressure is on. Um, I was wondering also about helping her develop a language for what she's actually experiencing that are
Right.
related to her suicidal thoughts.
Yes, I agree.
Um,
And
pull in other supports, adults in her life. There's like her coach, maybe do a Columbia suicide assessment, safety first, because there's a risk in actions of harm. So
yes.
lots of responses here.
Yeah, no, that's great. Thank you so
Yeah,
much.
yeah.
All right, guys, and I have one more for us, and then we can talk about whatever you want to talk about. So, this is a 15-year-old male, and he is in high school. He's a freshman in high school. Teen is the youngest of three siblings. His older sisters have moved out of the home. His parents divorced when he was 3. He split time in between both of the houses until his father passed away when he was 10 years of age. Teen reports a really good relationship with his mother. Teen has always been sensitive and more emotional than his peers. He has difficulty regulating his emotions, especially sadness and anger. He struggles and doesn't have many friends. He has experienced some bullying in middle school. Now he's in high school. Um, he's had suicidal thoughts, and he did have those after his father passed away. There was a period of a few months where he thought about dying so he could actually be with his dad. This was more of a wish to be dead, and he didn't think about actually killing himself at the time. When he was in sixth grade, so 12, he began thinking about hanging himself or walking in front of a car. At its worst, he was thinking about this many times a day, for many hours at a time. He struggled to stop thinking about it, and he viewed suicide as a way to take away the pain that he was experiencing. Last fall, so when he was 14, he began thinking more seriously about killing himself. He began writing a note, and he planned to take all of his pills. He has melatonin to help him sleep. His mother found the note and took him to the hospital. Since then, he has started therapy, began taking an antidepressant. Um, he seems to be doing a lot better, but for the past 4 months, he has had this wish to be dead, about once a week. He is now able to control the thoughts that he has with some effort and uses coping skills he learned in therapy. So, same questions here. What are some of those protective factors that you can see within this scenario?
Good relationship with mother.
Hmm.
Coping skills learned in therapy. Access to
Hmm.
therapy. Safety plan in place.
Absolutely.
Medication. Has learned to manage the thoughts to some degree.
Yes.
Older siblings to access for communication.
Yeah,
Ability to engage positively with helping professionals.
and that would be one thing I'd really love to know is what is his relationship with his sisters,
Yeah,
right?
yeah, for sure. Continues to attend school.
Yes. Yeah, and what are some of those
Mm,
risk factors that you guys see?
parental divorce, early loss of parents, access to
Hmm.
medication that can cause harm, ideation present for a few years, history of bullying, small social circle, um, history of some trauma, dysregulation, melatonin, having influence on hormone levels, even while the person is in active puberty, not
Hmm.
feeling a sense of purpose, um, the history of consistency around suicidal thoughts and behaviors, unresolved grieving,
Yeah,
spending a
those are
long
all.
period of time thinking about self harm,
Yeah,
effects of divorce, loss of permanency, bottled emotions.
thank you guys so much. These are all great. And then if you were to see this teen, as a patient, as a student, a neighbor, what would be some of the things that you would do? What would be your first action steps?
Find out his interests and passions.
Mm, that's a good one. That's a really good one.
Yeah, connecting him to community. Find a male mentor. Not a first action, but I would want a physician to reevaluate need for melatonin,
Mm-hmm.
trauma informed care and safety planning. Find out what support system looks like for him.
Yes. So I think and thank you all for participating in this exercise. I think the one thing that I want to bring to you all, if nothing, is that unfortunately there's not a one thing fixes all, right? Each case that you will encounter is going to have different protective factors, different risk factors, right? And that's going to determine what the next steps will be. And I think for Black youth specifically, these are risk factors and protective factors that may look very different from other groups of youth that you have encountered. And that doesn't mean that you can't do the exact same things that you guys are expressing. Just treating people like people, right? And just having conversations can actually be a really big emphasis on intervention. A lot of times, unfortunately, Black youth feel as if they are to be seen and not heard. I'm sure you've heard that before, that saying anyway. But when I was growing up, definitely be seen and not heard. If adults were having conversations, you would be doing some other things, right? And I'm sure that plays a role in other families as well. But I think for Black youth, that is something that continues to be present for them. So having a listening ear could actually be a point of intervention. So without further ado, um, I'm just going to put this up here so you guys can have it. Just resources again. Remember the 988 and the 741, those are US specific. But 211 is always available for those that are in Toronto. And then always go to the nearest emergency room as needed. Um, so without further ado, I will open it up for questions.
Thank you. That was fabulous.
Oh,
Thank you for
thank
taking
you.
us through all of that. That was really, really wonderful, thought-provoking. And yes, we have
Thank
988
you.
in Canada too. So
Oh,
that's
perfect.
a good thing to know. Yeah. Yeah. So we've got some questions in our QA. But I have one thing though. The 120% and the 144% increase was really alarming.
Yes.
And I'm
Yes.
wondering if you have, especially, it sounds like it happened since there's that specific increase after 2019. I'm
Mm-hmm.
wondering if you have any insights onto what you think those causes are, and if those are also areas of intervention. I know that sometimes we think of intervention as like you need therapy, but maybe intervention looks completely different from a public health perspective.
Yeah, no, that's really smart. Hmm. I don't know. As much as I would love to say
Mhm.
yes, I know the answer. Um,
Yeah.
2019. So let's see.
Well, it seemed to increase
2019.
also going into 2020. I was wondering if there was
Yeah.
pandemic effects and things like
No, let me
that.
see. Oh, that's my daughter.
Yeah,
Um,
so cute.
let me thank you. Let me see. I'm gonna get the graph up for you guys so you can see the graph. Do 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 do. Here it is. Okay. Dun, dun, dun. All right.
Especially, I know that you
This
had
one
that
here.
really great stat that showed how that social piece was so protective.
Hmm.
And during the
Yes.
pandemic, now you're isolated like
Right. Right.
times a thousand.
Yes. So I would definitely say, I would 100% say that COVID definitely played a role here, right?
Hmm.
Um, I 100% believe that to be true. A lot of Black individuals lost family members to COVID,
Hmm.
lost friends to COVID. So not only are you dealing with the isolation, but you're also dealing with the grief, right?
Yes.
And we know that unfortunately, if grief not dealt with properly,
Hmm.
um, you can be at higher risk for mental health
Yes.
concerns, right? And we know that mental health concerns are associated with suicidal thoughts and behaviors, some of them. So I definitely would say yes, the pandemic did play a role between that 2019, 2021
Hmm.
time frame. Um, but also, it was just a scary time, just in
Yeah.
general, right? Um, we didn't know is the vaccine safe? Is it not safe? It's out, it's not out. What's happening? Who's happening? When? What? I mean,
Yeah,
things changed so drastically
they
during that
did.
time frame. And I think that definitely did play a role, 100%.
Yeah.
Yeah.
Okay.
Yeah.
There's someone's also mentioning the impact of social media as well.
Yes. Mm-hmm. Yep. Yep.
Yeah.
So back in my day, I always say that. But when I went to college, we didn't really have social media until Facebook came to my university and decided to like have us as a testing site. But that was in 2001, right?
Mhm.
So now social media is just a thing that people do every single day, all day long, potentially. And unfortunately, it has negative effects on individuals. But I also believe that it could be a tool that can have positive effects as well. But it's not used, majority of social media platforms are not used in a positive light, for lack of a better
Yeah.
term. There are, spots here and there, right? But that doesn't mean that it can't be used in that way. I know for myself, I'm the least social media savvy person in my household, I would say. But I do have a suicide awareness group that I'm a member of. I have a mental health for Black men group that I'm a member of. Just being able to connect with people in that way,
Yeah.
I think it can be really helpful
Mm,
to be able to talk to people that are experiencing those
yeah.
things, um, or have experienced those things. But it also can put negative thoughts into our minds as well.
Yeah, for sure.
Yeah.
Um, so another question here on geographic differences
Yes.
in suicide rates for Black youth, and if there's any theories to help explain those differences if they exist.
Yeah, so let me put up the map again. So this is for Black youth specifically. So I looked at 2018 to 2023. And what we found is that for our increases, specifically the South and the West, for Black youth 5 to 17 years of age, had increases present. But for our Midwest and our Northeast, they had decreases. And actually, the Northeast did the best, with a 37.2% decrease.
Hmm.
So that is, yep, that is present.
Yeah.
And DC is considered a part of the South, just so if everybody wants to know.
Yeah.
Washington, DC. Hmm.
Yeah. Okay. But do you have any ideas around like why there was like increase in some places, decrease in some places?
Yeah, I think I'm in New York, so everybody knows. But I was born and raised in Massachusetts, so I've been in very progressive, mental health supportive states. And I actually uh, lived in Ohio and Pennsylvania for quite some time, in the middle of Pennsylvania. And what I noticed is that in the middle of Pennsylvania, even though we had a huge university, Penn State, a
Hmm.
lot of mental health providers were very limited within
Hmm.
state college, right? Now, mind you, this was 2000, 2004, right? Um,
Yeah.
it's probably gotten a lot better now than what it was, but I noticed that services were lacking in
Mm.
those places, for youth and for even adults. So I think mental health access is actually a lot less in the South. So that would be
Right.
part of my thought process. But in the West, I'm not sure because California is one of those really progressive, mental
Yeah.
health heavy states.
Hmm.
Um, but it's only one, right?
Mm.
Um, the other states, I'm just looking now. So the other state that was included that may have a unfortunate reason why, or maybe one of the reasons why, Alaska. So Alaskan natives have a huge um, rate of suicide
Mm.
deaths. So Alaskan natives are actually included into this 19% increase. That might be one of the reasons why we're
Yeah.
seeing that increase present.
Yeah.
Um, but yeah, Hawaii's in there, New
Mm.
Mexico's in there, Washington, Utah. So maybe again, um, access might be a
Mhm.
point, but also stigma might be stronger in those states than in others,
Mhm.
for Black youth specifically, but I'm not 100% sure what those things are that are
Okay.
driving those increases specifically.
Okay.
Yeah.
Um, there's another follow-up question actually
Yeah.
to this around uh, just actually within the Black population, is there
Hmm.
certain groups that we're seeing more impact, like whether it's African, Caribbean, Afro-Latino?
Such a great question. So, unfortunately, getting that data is really hard to get. So, when you look at national data from the government, unfortunately, it does not break down
Mhm.
Black into those groupings. So it's all encompassing. So it would be really hard to find a database to actually look at specific groups within Black and within Hispanic even. So Hispanic is one big group, but we know 100% that not all Hispanics believe in the same things. Not all Hispanics have the same cultural backgrounds, right? But they're all encompassed into one big group. So I 100% agree that to be able to do suicide prevention effectively, going to that group specifically that you're trying to actually do that intervention with, you have to get that buy-in. You have to get that feedback. So
Mhm.
we have a group here in Rochester that it's like the nurses of the Caribbean and African. It's a group. So I'm not sure if they would have data specifically
Mhm.
on Africans versus Caribbean, but that would be a potential place to look. So looking within those groupings, in those organizations that serve those groups, if that would be a spot to actually place some energy to understand better which groups need more intervention versus others.
Right. Yeah. I mean, I know there was a question about Canada. There's not much data on Black youth suicide rates, and you're actually completely right. And in Canada, they don't break it down by race. They'll do gender. They'll do age.
Yeah.
They don't do race for one of the reasons they say is for confidentiality, privacy, because like the
Oh,
number of people within a region might be small, and so it could
um,
potentially identify who they are.
yes, yes.
So, however, I literally was emailing a colleague about this like a couple of weeks ago about because he does some work with the coroner data in Ontario, and there's might be some opportunity there to get more information, at least in the Ontario data set.
Yeah.
So, so add this question into your research. We need to know about this, and we don't have enough information on it. Hopefully that's to come.
Yes, no, that would be great.
Yeah. So a couple more questions if you don't mind.
Yeah, please.
So another question is about how much of cultural history of medical racism as part of intergenerational trauma get in the
Mm,
way of consenting to speak with support staff or help seeking behaviors. So um, is this discussed with youth or versus like seen as like are you just kind of seen as non-compliant or not wanting help?
no, that's a great, great, great question. So, unfortunately, for those that do not know, medical centers and hospitals and the people that you would think would want to actually help, were hurting in the
Mm,
US. And I'm sure in other countries as well. I shouldn't just say in the US. We're hurting Black individuals and caused Black individuals to actually be very, very sensitive to seeking out mental health and even physical health expertise, because they were worried that they were going to be experimented on, right?
mhm.
Because they were experimented on. So I'm sure you guys heard of the Tuskegee experiment, right? And many, many other experiments that were done to Black men and women and others. And in order to, you know, allow medicine to move forward, right? So, yes, absolutely plays a role. 100% plays a role. I speak with Black families that are in my research study, and a lot of them are still worried. Even, me as a Black person coming to them and asking them questions. Who are you going to report this to? Is it going to be confidential? And we go through a lot of information to make sure that we make people feel comfortable with telling us, if they've had thoughts about suicide or if they are having thoughts about suicide,
Yeah.
um, and making them feel like not just another one, but actually feeling like a person that has
Mhm.
an history and that deserves to be heard. So, unfortunately, yes, stigma plays a huge role, trauma plays a huge role, and not only lived trauma, but trauma you've heard of, right? So, if you hear from a family or a friend that, I had my daughter and she was on the inpatient unit and they treated us so horribly, Why would you want to experience that for yourself? So yes, I believe that those things do play a role in seeking services. Um, and unfortunately, we have a lot of wrongs that we have done within the field of medicine. Um, and it's going to take a lot of time. And that's why I said buy-in is key. Building that trust is key in order to actually get the help that's needed for the families that you're working with.
I think that's this is such an important point to touch on because I know like even like as a researcher, we'll say that anytime you're working with historically marginalized groups, especially Black groups that have been severely mistreated in research, they have
Yes.
every right not to trust you.
Hmm.
So suck it up, Buttercup. Like they have every right not to trust
Yep.
you, and it's up to you to earn that trust. And
Absolutely.
it's a question of like, why are you doing that work? Why are you approaching this community? What is your intention? And like, what's your value for doing this? And
Yes.
that is such an important piece also as clinicians and hospital settings, because, you know, I know that one slide you had was talking about, um, mentioned community, and there was some Canadian data that Black youth are more likely to access services in the community than the hospitals.
Hmm.
And why is that? Well, we know why that is. It's because in the hospitals, they're not getting the care that they need,
Nope, they
right?
aren't. They
So,
aren't.
and that's
No.
not their problem. That's our problem. You know what I mean? Like, so like that's something that we need to, what I see as kind of like an important thing for us to address as hospital settings, research, all of that needs an overhaul on how we're approaching this. So I thank you for bringing up that point.
Yeah, absolutely.
Yeah.
Oh, thank you so much for the question.
Yeah. Um, I'm wondering if you have, I know we're over time. I wonder if you have time for a couple of other questions, Ariel. If
Yeah,
you don't, no
sure.
worries. Um, uh, so one person was also asking about if you could speak more about any interventions that as clinicians they can implement for some of their higher risk Black youth, and PS
Hmm.
amazing talk.
Yeah, no, thank you. I think, there are a couple. Um, so there is one, let me look it up. I know, I'm sorry. I should know them off the top of my head, but I
Oh, that's
don't, which is
okay.
so bad. Um, where is it? Okay. So there's this adapted coping with stress course. So ACWS, it actually came out in 2021. Robinson is the last name. Lavome, Lavome is the first name. It's supposed to be school based, but it could potentially be something that could be implemented in a clinical setting as well. I know that they received funding from NIH to actually look at a larger trial. But basically, the reason why I say this is the way that she adapted this. She brought Black youth into her office and just put all the modules out on the table and said, "What do you think?" And
Nice.
actually adapted the actual program to be more Black youth specific.
Hmm.
Um, so that is something that may be an opportunity to look upon. But also gatekeeper trainings. So I believe gatekeeper trainings are actually really, really good to implement, but where they're being implemented is something to consider. So one thing I would definitely say is that barbershops, beauty salons, urban leagues, after school programs where Black youth are attending, like Boys and Girls Clubs, or even at the rec centers, those gatekeeping trainings, like making sure not only to educate the leadership and the people that are engaging with the kids, but the kids themselves. So
Mm.
engaging with them and allowing them to say, okay, these are the things that we should be looking at. And it creates this kind of community of safety, so to speak, where kids feel okay, this is a safe space, but not only that, my friend is struggling and I need to talk to someone about that so that they
Yeah.
get the help that they need. So I think gatekeeper trainings is a really good way of actually engaging Black youth, families, places that they are. There's actually, I think in
Yeah.
Chicago, Illinois, I think there's like actually a barbershop gatekeeper training program that's gotten a lot of publicity where he goes
Awesome.
in, yeah, and he just trains all the
Yeah.
barbers.
Yeah. I feel like I
Yep,
saw some research on that even at the International like the Suicide
yep,
Research Conference in Boston. Yeah. Yeah.
yeah,
That's yeah, you have to meet people where they're at, not
right.
expect them to come to you. Yeah.
Yes.
Has your research or other research shown that racism is directly connected to suicidal behaviors?
Great question. So we actually, so my research specifically, we're looking at discrimination right now. In how many? Two of my studies. We haven't looked at the data yet because we're still collecting the data. But yes, if you look up, there's a ton of articles that recently, well, not a ton, some articles that recently came
Mhm.
out that look at racism and Black youth or Black individuals and how that relates to suicidal behavior.
Okay. We'll
Yeah.
just end off on one last question, if you don't
Yes,
mind,
please.
because I think this is an important one. What are some ways to help Black parents understand the unique challenge to our Black youth in maintaining positive mental health practices, especially when disconnected from culture and community? How can parents struggling with their own regulation skills help kids develop positive coping strategies?
Yeah, no, that's a great question. I think it is
Hmm.
hard. It's really hard, right? When we as parents, I'm a parent, so I can talk about that. When we're struggling, how can we help our kids to feel better, to do better, to not be struggling as much as we are? I would say honestly, family therapy. Why not, right? Um, it's one of those things where, and just being real with your kids, being real with them and not even having those conversations actually about mental health and just doing that at a young age would actually be beneficial. So it's not, oh, we go straight to suicide. No, talk about emotions, talk about how you're feeling, how you're thinking, putting words to those emotions. What does it feel like when you feel sad? What does it feel like when you feel angry? What do you do? When you feel angry, this is what I do. What do you think we both could do to feel better when we feel sad? Um, just trying to have those conversations, even at a really young age, can actually normalize that mental health and emotions and well-being and feelings are actually things I can talk to you about. So building upon that foundation, then when things get harder, when suicidal thoughts and behaviors and thoughts and even NSSI comes into play, then you can have those conversations with those kids and not feel so intimidated, right? Because you've already set that foundation, so to speak, with the feelings and the thoughts and the emotions, and having that open dialogue that's present about those feelings, thoughts, and emotions. So I think it's okay to have those really early and often, um, and just, having check-ins, whether that be just randomly, is really, really, really important.
Hmm. Yeah, we hear you say like just create some space for those
Yep,
conversations.
yep,
Yeah. Hmm.
yes. Yeah,
Well, I thank you so much, Ariel, for taking
you're
your
very
time
welcome.
to share all of this with us. This is amazing. Really appreciate all the work that you're doing. Looking forward to meeting you in person soon at
That's right.
the conference
Yes.
too. And for everybody, our next talk is going to be on Monday, March 9th at 12 to 1. Dr. Kim Van Orden is going to be speaking on social connection and suicide risk, which is a kind of a good segue from today
Yes.
as well. So thank you so much, Ariel, again, and hope you have
Yes.
a lovely day. Hope everyone has a lovely day, and
Yes.
everyone
Thank
is.
you.
I'm getting great talk, fire signs. Thank you,
Woo!
thanks so much. Great job. It's like all running through the chat as well.
Well,
So thank
thank
you
you
so much,
all.
Ariel.
Thank you. Have a great